Hi, I'm Josh McDonald.
And I'm Miranda, and we are Hand Therapy Academy.
So, we're trying to sprinkle in a little bit of this in a couple of different podcasts. We want to talk a little bit today about another one of the articles or ASHT posters that we've put out, just kind of help kind of share more knowledge about stuff. Miranda did one not too long ago about trigger finger treatments. Miranda, you want to tell us a little bit about it?
Yeah, so I think I should start with the very first background of how this all started. I was doing my capstone at Mayo Clinic. This was a very long time ago, and we were doing, or basically the standard of care was for the patient to get an injection in the A1 pulley for trigger finger, and then they would get sent to hand therapy immediately for immobilizing the PIP joint. So it started out that way. And part of my capstone was doing a systematic literature review and going through all the literature and finding out what out there shows that splinting and injection together are better than injection alone or splinting alone. So that's where this all started at, and that was a long time ago. And during that time, the first part of the project was to look at, does it matter what joint you immobilize? And for a trigger finger. And we found that it didn't really matter as long as you prevented the triggering. So you could immobilize the DIP as long as they didn't trigger when they went into a fisted position. Or you could do the PIP or the MCP. It really didn't matter. You just wanted to prevent that triggering from occurring wherever it occurred at. So from that lit review, we decided that it didn't really matter um, where it was done at. And then a few years, and that actually was my first poster at ASHT with Mayo Clinic. And that was an exciting one because that one won Best Poster. But I think that
Nice.
was mostly because of the work that they were already doing at Mayo Clinic. I just happened, my timing was good. Right. And I was the one with the most time to put it together. So that was kind of a cool project. And then later on, we ended up doing the clinical guidelines for trigger finger at the Mayo Clinic. So we acquired more literature and we ended up redoing the literature and submitting another poster. And basically, the outcomes show that it is slightly better if you add a splint while you after an injection. So I think the studies where injectional or splinting alone was around 50 to 60% effective if it was in the early stages of triggering. And then in the next stage was we compared injection alone, and that was pretty effective. But with injection and splinting together, it was like 5%. I can't remember all the data, but it was like 5 to 7% more. So it was basically just showing that splinting is a little better than injection alone with treating trigger finger. And the first part was like, it doesn't matter where you immobilize them at.
Okay, okay. Lots of good information there and very applicable to what we're doing and what we're teaching patients and how we're picking to do things. Do you have a preference on which joint you like to immobilize?
Honestly, I show the patients and I let them decide. And sometimes I say, just take both and change them out based on the functional task. So the last person I had he was a wound care physician. And both would do the job, but there were certain tasks he couldn't do with the DIP immobilized, and there were certain tasks he couldn't do with the PIP. So he would switch them out based on whatever job he was doing.
Interesting. Okay. But in both cases, like an off the shelf ovalate?
Um, yeah, I did end up giving him I think for the DIP, I ended up making him something a little bit different because he had shorter fingers and it was slightly too
Okay.
long. So I just gave him like a little, like my own version of a Novolate that he would put on.
Okay. Okay.
The
Cool.
same principle. It was basically the same principle. And if an Ovolate would have worked, I would have done that.
Okay. Do you like to immobilize the MCP with that paddle in the palm? I've heard it called a light bulb splint because it looks like an upside down light bulb. Do you use that very often?
Yeah, I did sometimes. Not, it's definitely not my go-to. My favorite is probably the PIP. But if I have a patient that there's some circumstance where their PIP is getting stiff or something like that, I might do that. How about you?
I rarely immobilize the MCP. The DIP, I feel like I have a hard time not just falling off all the time.
Yeah.
So 90% of the time I'm PIP. The My next is probably MCP, and that's usually for patients who have like a Bouchard's nodule, or maybe it's not even Bouchard's nodule, they just have very bony joints, and getting that oval 8 to fit right over a bony joint, because once it slides over the joint, it's loose on their finger, but it has to be a bigger size to get over that. So then I'll do that paddle light bulb splint thing, because that just has to go around P1 with a Velcro in the back. But I feel like that palmar piece is a little uncomfortable. You're trying to cut around the thenar crease and all that. So it gets a little
But
bit more involved.
the thing that I like about the MCP, or the MCP one, is that it does avoid them putting pressure over their A1 pulley. So I think it's good for that aspect. Like if they're doing a lot of driving or something and they have pressure in their palm, or they have some activity that's putting a lot of pressure over it, then I do like that as an option. Or I will tell them to get a padded glove, or I've even sewn them like the neoprene option of that.
Yeah, yeah. I think you can get on Amazon trigger finger splint or something like
Oh, the
that. Yeah,
trigger
yeah.
finger solution.
Yes, that's what it is.
Yeah,
Yeah, yeah.
I basically sew a version of that, and I've even done where I've made a pocket and put the thermoplastic inside of it.
Oh, okay. I like that. Yeah, and I feel like that, like you said, if they have pain with pressure directly to that A1 pulley, or like when they're putting their hand on a steering wheel, or if just sometimes that oval 8 cuts into the web spaces on either side and it just doesn't sit right on their hand. So you can custom make one out of an Orphicast or something like that, or just go with a thermoplastic paddle there. And if they're happy with that, go for it.
Yeah. And I do want to say, for all of the studies, it wasn't about, none of them included the thumb.
Yeah, whole different bag when you're talking
Yeah.
about the
So
thumb.
like that has the thumb, we know, is like the conservative options aren't as successful as the other digits.
Yeah.
When I say conservative, I mean injection and splinting.
Yeah. And I'll have patients that come in for the conservative management of the thumb, sometimes from a surgeon because they don't want injections, they don't want surgery. They're like, I'm going to try the conservative. And I've had a patient who just wanted to keep trying, wanted to keep trying. And I say, I'll give it 6 weeks. And if we aren't noticeably better, maybe not 100%, but noticeably better with triggering and pain in that thumb, this isn't the answer. It's the thumb is just so stubborn.
Yeah. I know. And then I think, and then you're like educating the patient. There's different stages of triggering. If the stages are improving, I'll go over all that. But a lot of times, those patients that want conservative of the thumb, it's not as successful. Do you ever have luck with it?
I have had one patient just recently that another one of our therapists was treating, and she very much went. It took a long time, but she was going. She's like, I refuse to do injections, and I'm not going to do surgery. I want to do this. And gosh, I feel like it was 3 months, and we just kept checking, and she kept progressing backwards through the stages of trigger finger, but it was a slow, arduous walk. And now she says it doesn't trigger on me ever, and I don't have pain to it. So
That's amazing.
yeah, yeah,
I like
it's
those stories are good stories.
yeah, yeah, it's a good story. It felt in the middle of it like, man, are we just banging our head against the wall? But she kept talking about small incremental changes, so that's
I
what
know. And
counts.
it does show you that, there are exceptions to the rule, right? Not everything is an absolute. We go off of our experiences, and of course we go off the research, but there are those outliers that get better when we think, maybe they won't, or vice versa. You think they're going to get better and they don't.
Yeah, yeah. It's interesting to hear you say that the conservative splinting only was 50 to 60% successful. I feel like clinically I see it much more successful than that, but that may be who the sample size that comes into the clinic is already in better position than the people who get to the doctor first and just go to surgery. Like maybe the sample size is different. I don't know, but I feel like I see better than 50, 60% success rate.
Yeah, like these numbers are from a while, so I'm like recalling off the top of my head, but they're close, guys. They're close.
Yeah, yeah. We're going to quote you on that for
Yeah,
sure.
yeah. Don't get me on it. It might be off by like 5% or something.
Yeah, yeah. But still, I would have thought it'd be somewhere in the 80% because I feel like we have pretty good success with the ovalate splinting or, custom or whatever.
Yeah.
Yeah, yeah,
But how many times do you have that? Like I had a patient last week, and they were like, the doctor wants to do surgery, but I refuse, and I'm trying. And they said therapy won't work. So a lot of times the doctors are telling them therapy won't work either. And
yeah.
those are the ones I really love when they get better, because you're like, this therapy does work.
Yes. And I've talked to patients before, and we use the analogy when you're a hammer, everything looks like a nail. When you're a therapist, all of our problems can be fixed with therapy. When you're a surgeon, just jump to surgery. That's what you're here for. We can fix your carpal tunnel with surgery. We can fix your trigger finger with surgery.
Yeah.
Just do the surgery. Therapy's not that effective anyway. Well, you ask me, and I'll say, why are you going to cut yourself open? Let's try the conservative for 6 weeks and see what we get. Yeah.
Yeah, but I do, and to be fair to surgeons too, I know that they're pretty careful too. They're not just having people go to surgery to go to surgery,
Yeah. Yeah.
and you know that too.
Yeah. 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 Well, it's just interesting to hear some different perspectives on what is a normal, pretty common diagnosis that we see, but also something that Miranda got a chance to do some poster presentations at ASHT a little while ago. So very cool. Thank you for sharing, Miranda.
You're welcome.
And if you have any questions, please feel free to reach out to us at our email, info@Hand Therapy Academy, or on any of our social media platforms with the handle Hand Therapy Academy.